Yes. And then, okay, so Dr. Naqash, is that how you pronounce your last name?
Correct.
Okay. All right, so let me just briefly introduce our speaker, Dr. Abdul Naqash. He is an advanced fellow in the Early Clinical Trials Development
I
Program.
think you have the wrong bio. I think I
Oh
had
no,
said,
the
yeah.
bio. Okay,
There's
hold
an
on.
updated bio that the bio that they used initially was
Yes.
the wrong one from a couple of years back.
So the
Okay,
one that I sent you
okay.
yesterday,
It starts with received his medical degree at the
yeah, that
government.
one.
Okay.
Yes, yes, that's the right one.
Okay, fantastic. So, updated news. Our speaker, Dr. Naqash, received his medical degree at the Government Medical College in Srinagar, Kashmir. He
Yes.
completed internal medicine residency training at the University of Buffalo / the Catholic Health. Subsequently, Dr. Naqash completed his subspecialty clinical training in HEMONC at ECU, or East Carolina University in Greenville, North Carolina, and an early phase clinical trial fellowship at the National Cancer Institute in Bethesda, Maryland, in the Developmental Therapeutics Clinic. As part of the TSET Phase 1 program at the Stevenson Cancer Center, Dr. Naqash is focusing his interest in drug development and incorporating a genomically driven approach to early phase clinical trials. He's also interested in lung cancer, immunotherapy biomarkers, understanding resistance patterns to immunotherapy, and immune toxicities. Dr. Naqash has led and collaborated extensively with national and international leaders in the field of immunotherapy. Some of his work has been published in high-impact journals, such as the Journal of Clinical Oncology, JMA Oncology, the Journal of Immunotherapy for Cancer, Clinical Cancer Research, among others. He has been the recipient of several coveted nationally recognized awards, including the ASCO SITC Merit Award, the ASCO Merit Award, and the ASCO Young Investigator Award, and the NCI Directors Award. He is an executive member of the SITC Early Career Scientist Committee, ASCO Trainee and Early Career Council, and the AISLC Career Development Committee, where he's actively involved in working towards developing educational initiatives for early career investigators. He also serves as the social media editor for the JCO Precision Oncology and is member of the ASCO Social Media Working Group, developing strategies to facilitate outreach for ASCO journals and ASCO meetings on social media platforms. So we are very honored and very excited to have him speak to us today. So Dr. Naqash, I'll pass it over to you and let you share your screen. If you have any difficulties, let us know.
Thank you so much for the invitation and the kind introduction. Let me share my screen. Can you guys see my screen?
Yes, looks
Is it
great.
the presenter's view or the...
It is correct, yes.
Okay. All right. So today we'll be talking about something that I have been getting very interested in. As you mentioned, my background is in early phase therapeutics. So I do lung cancer also, and I do a lot of biomarker research. And last couple of years, I've had this intrigue about neuroendocrine tumors, which is what brought my interest into the space of large cell neuroendocrine carcinoma of the lung. And obviously, this audience is very privy to other neuroendocrine tumors. And I'm very interested in discussing some of the insights that I have gained or some of the research that we have been doing in large cell neuroendocrine carcinoma of the lung specifically. So large cell neuroendocrine carcinomas, obviously neuroendocrine carcinomas are at a spectrum. And from a diagnostic criteria standpoint, when you look at large cell neuroendocrine carcinomas, they fall into the same neuroendocrine carcinoma grade 3 category as small cell lung cancer. The interesting fact is a lot of research, a lot of efforts are directed at small cell lung cancers, but large cell neuroendocrine carcinomas are equally bad, which is what we'll talk about subsequently. And unfortunately, there's not a lot of research being done in this space. From a pathological standpoint, when you look at these large cell neuroendocrine carcinomas of the lung under the microscope, they generally tend to have 9 to 10 mitoses per high power field. They're high grade, meaning Ki67 is more than 40% in general. And from a incidence standpoint, it's around 3 to 5% of lung cancer. So definitely less than small cell lung cancers, but nevertheless very aggressive. Does have an association with smoking, and around 40 to 50% individuals are metastatic or have metastatic cancer at the time of diagnosis, versus, majority of small cell, for example, that are metastatic at diagnosis. As I mentioned, the Ki-67 index, which is the rate of proliferation that these tumors exhibit, is on the higher side, which differentiates them from the atypical and the typical carcinoid, and they fall in the range for small cell lung cancer. Now, from a diagnostic criteria standpoint, there are certain criteria that the WHO utilizes to diagnose, but the important thing here to remember is unless and until you have adequate tissue to diagnose large cell, it can be misidentified and not recognized, which is not entirely true for small cell lung cancer, which can be diagnosed on fine needle aspiration biopsies also. But large cell is one of those tumors. LC-NECs are those tumors that represent a diagnostic challenge or dilemma if you don't have enough tissue, and I'll give you some examples subsequently. But from a criteria standpoint, the WHO utilizes the neuroendocrine morphology. The tumor should have organoid nesting, trabeculae. They should have a high proliferation index, as I mentioned. They should have a decent amount of necrosis. And they should also have the immunohistochemical expression for at least one of the neuroendocrine markers that we generally see in neuroendocrine tumors, such as chromogranin A, synaptophysin, CD56. And as I mentioned, on the marker standpoint, IHC marker standpoint, LC-NECs have a very similar pattern to that of small cell, but morphologically they can be differentiated because of the cytoplasmic abundance that LC-NECs have in the presence of nucleoli and the nuclear size. There's also a category of mixed large cell neuroendocrine carcinomas that have foci of squamous and adenocarcinoma differentiation, which can coexist, and they seem to be a separate category, and not a lot of research has been done in those tumors. And these LC-NECs also have positivity for TTF1, which is one of those markers that we use to say that pathologists use to identify whether tumor is of lung origin, but this can be present in only around 40 to 50% of the cases. As I mentioned, morphologically, the small cell and large cell tumors differ. Small cell, as you see on the left, shows these sheets of small cells with scant cytoplasm and granular chromatin. And on the right, you see LC-NEC tumor with a unique representation of organoid nesting and tumor cells that have abundant eosinophilic cytoplasm and prominent nucleoli and granular chromatin. They do have, LC-NECs do have a aggressive biological behavior. As I mentioned, they have a phenotype, clinical phenotype similar to that of small cell lung cancer. We all know, the audience very well knows how bad small cell lung cancer can be. The interesting fact is that LC-NECs have a 5-year survival of less than 10%, which is very similar. This is data from SEER database, recent SEER database analysis. And this is very similar to small cells. So the fact that these tumors behave as badly, if not worse than small cell, is very alarming. And unfortunately, there's a very limited amount of evidence, both biomarker-wise and clinical trial-wise, in these tumors. The other interesting thing is that LC-NECs do tend to have higher FDG uptake. So if you have a patient where you got a PET scan done, and the PET scan is lighting up aggressively, but on the biopsy, the pathologist says that this is atypical carcinoid, there's something likely wrong there. There's a disconnect. It could be either related to the biopsy size of the tissue. Maybe that was an FNA and that's why it was misdiagnosed. But these tumors do have an aggressive biology, so they are FDG avid. And one of the reasons that has been identified is that they have higher expression of this glucose transporter 1, which results in higher FDG uptake in these tumors and aggressive behavior in general. From a clinical presentation standpoint, these tumors do tend to present at earlier stage compared to small cell lung cancer, which a lot of patients will present later stage and are much aggressive. They do tend to occur in the peripheral, localized in the peripheral areas of the lung, and especially in the upper lobes of the lung. But one of the interesting facts also is that they tend to have a higher percentage of brain metastasis, and this is again based on recent SEER database analyses when you compare LC-NEX of the lung to small cell lung cancer. Again, from a comparison standpoint, non-small cell lung cancer represents around 76%, as you see here. Small cell represents 15 to 20%, and LC-NEX around 2 to 3%. I would rather give it around 2 to 5%. I think one of the reasons why we say the incidence is 2 to 3% is likely because of lack of adequate biopsies, and maybe the percentages would go up to 5 to 7% perhaps if we had adequate biopsies and appropriate diagnostic approaches. Histopathologically, I mentioned they're different. They're different from small cell based on the size of the cells, the abundant cytoplasm, the prominent nucleoli. Immunohistochemical marker-wise, I mentioned that TTF1, which is the thyroid transcription factor 1, is only present in 40 to 50%, while it's present in 80 to 90% of small cell lung cancer tumors. And localization-wise, they're peripheral, while the small cell lung cancers often tend to be central. Now, this is an example of a patient of mine, and I want to highlight how important biopsy is. So this is the PET scan of an individual that presented to me last year. And you see the supraclavicular lymph node here. You see the mediastinal mass here that's close to the heart that's lighting up on the PET scan. And the initial biopsy, as I pointed out using this arrow, showed a carcinoid tumor. Now, again, there's a disconnect. If it was a carcinoid tumor, then why is it lighting up so much on a PET scan? So I asked for a core needle biopsy of this subcutaneous tissue or subcutaneous lesion that this patient had. And as expected, that biopsy showed that this was large cell neuroendocrine carcinoma. It was having a very high Ki-67 proliferation. So the theme here is that if you don't have adequate biopsy tissue, diagnosis can be difficult, and you may miss a potentially aggressive tumor because of those diagnostic inaccuracies. That's why core needle biopsies are preferred, especially if you can get one. So if you have if you are not completely sure about the diagnosis and you have access to tissue, or you can safely biopsy something, again, as a core needle biopsy, that's preferable to not do anything and proceeding with what the initial diagnosis was provided as. Now, again, this is another important feature of large cell. As we move into the genomic space of medicine, we tend to do more and more genomics and molecular testing. There has been some data looking at what is the genomic and transcriptomic subtyping of large cell neuroendocrine carcinoma. So genomics is more or less the DNA, and transcriptomics is the RNA expression, which is downstream of the DNA. So the interesting thing is that there's two types of large cell neuroendocrine carcinomas of the lung that have been identified. Type 1, as you see in the figure, is categorized based on the presence of TP53 mutation with STK11 or KEAP1. And type 2, on the other hand, is categorized based on the presence of RB1 mutation with TP53 mutation. So based on these mutational identifiers, there are two types of large cell. But the interesting thing is, when you look at the RNA expression, it's reverse. So tumors that are type 1, and these type 1 mutations are mutations that non-small cell lung cancer has, or adenocarcinoma of the lung have. And TP53 RB1 mutations are the ones that small cell lung cancer has. So you would expect that downstream RNA expression profiling would suggest that tumors that are small cell-like genomically are also small cell-like transcriptomically, but that's not true. That's why I've highlighted that in red, where type 1 has mutational patterns similar to non-small cell, but the gene expression profile is reverse. It's similar to that of small cell. Whereas type 2, which is genomically like small cell, transcriptomically, it is similar to non-small cell. So it reverses it. As you see here, expression of these markers such as Notch high in type 2 is opposite to Notch low in small cell. So that's why transcriptomically, these tumors behave reverse of what you expect genomically, which is an important concept in these tumors. Again, this is some data looking at some of the biomarker data, information in these tumors. When you classify these tumors using, there was a recent data set 2 years back published at ASCO or presented at ASCO using 467 samples of large cell. Around 73% were non-small cell-like, as is shown here, and around 25% were small cell-like. This is based on those genes that I mentioned, TP53, RB1, STK11, KEAP1. And then when you look at tumor mutational burden, which is a potential biomarker for immunotherapy, not necessarily in all tumor types, these tumors actually, 40% or so have high TMB, meaning TMB more than 10 mutations per megabase. And as you see on the right, the median TMB for small cell and large cell of the lung, it's pretty similar. It's 9.9 or 10. And in some data, there's also suggestions that large cell neuroendocrine carcinomas have higher tumor mutational burden than small cell lung cancer. So the idea here is that these tumors seem to be immunologically active in some ways based on the tumor mutational burden. And they also have around 21% have PD-L1 positivity, meaning PD-L1 more than 1%. So these are interesting data to understand and hopefully help in identifying what therapies that we can utilize in these individuals. When you compare genomically non-small cell and small cell in large cell neuroendocrine carcinomas, this is a data set from a Boston group that was just published. They had 1,400 or so patients. They did this recategorization based on the genes for these 1,400 tumors that were pathologically identified as large cell neuroendocrine carcinomas. And as you see here on the top left, in the left figure, RB1 TP53 are the two mutations in the small cell like large cell cancers. And on the right, you have these group of mutations, STK11, CDKN2A, MTAP, FGF, which seem to be enriched in the other LC-NEC samples. And based on these, they were able to categorize around 39% as small cell-like, which means that those tumors had TP53 RB1. 37% were non-small cell-like based on some of these mutations, STK11, KEAP1, MTAP, and then a proportion was still unclassified. But the other interesting thing is when they reassessed these tumors, the non-small cell-like and small cell-like, there is a proportion of patients within this subset that actually have driver mutations that are targetable. So ALK fusions, KRAS G12C, for example, or RET fusions. It's not a lot of patients, but nevertheless, it is a few patients that would potentially benefit from targetable alterations that can benefit from precision medicine-based approaches. And same thing for the small cell-like, even though the proportion was much smaller, there was a couple of patients that had HER2 mutations or had EGFR driver mutations that would benefit from precision medicine approaches. So this group also tried to elucidate whether there's a potentially better genomic classification system for LC-NECs. Like I mentioned, we used the TP53 RB1 to classify them as small cell-like and KEAP1, STK11 genes to classify them as non-small cell, but this group also suggested, based on their data, that these additional alterations, it's called CDKN2A or MTAP or SMARCA4, FGFR, that I've highlighted here, can potentially help identify more patients that are in the non-small cell-like subtype of large cell neuroendocrine tumors, because some of these mutations seem to be more enriched in the non-small cell-like subtype versus the small cell-like subtype, as you see here. So it's 41% for non-small cell-like in the CDKN2A cohort versus 3.4%, suggesting that this could be a differential gene that could be used to recategorize some of these patients. And some other folks have looked at what would categorize these LC-NEC tumors as immune hot, meaning immunologically active. This is some data from Asia looking at 37 large cell tumors. And what they basically identified was that tumors that are tumor mutational burden high are the ones that have activation of the WNT or the Hippo pathway. And these are two pathways that are involved in cell cycle regulation. So when you have activation of the Hippo pathway, then these cells try to proliferate rapidly. And the idea here is that when cells proliferate rapidly, it leads to accumulation of damaged DNA, which leads to replication stress and that likely leads to higher tumor mutational burden. But that's just some suggestion that there are some subsets within LC-NEC tumors that are likely immunologically active and may benefit from checkpoint-based therapies. So real quick on the management side, early stage, because there's not a lot of data, unfortunately, in this space, there's very, very limited, very few prospective trials. The idea is if you identify an early stage an LC-NEC tumor using adequate biopsy, then you should resect it if possible, and then give adjuvant chemo. And more or less people use carboplatin etoposide or platinum etoposide that is generally recommended as an adjuvant post-resection treatment. And there's just one trial, basically prospective adjuvant trial, that suggested an overall survival of 88% or so versus 47.5%. And the control arm here was actually historical controls. It did not have an active control arm. So that's where the data is a little finicky. But nevertheless, the idea is if you resect the tumor and you have negative margins, then adjuvant chemo is appropriate, in earlier stages included. And then if you have node-positive disease where you need to give chemoradiation, you would use the same approach that you use for example, small cell lung cancer, for that matter. Some of the therapy-related complexities are more or less an evolving concept in large cell because there's not a lot of data with respect to what works well in this space. If you go to NCCN recommendations, they will suggest that you could go ahead with a non-small cell-like treatment approach, and you could also go with a small cell-like treatment approach. So both are considered fine and okay, and I have used both. But clinically, and I'll show you some data subsequently, it doesn't look like either of them leads to any significant benefit in individuals. Now, conceptually, there has been some data, preliminary emerging data, suggesting that there's high level of thymidylate synthetase expression in this tumor, which leads to less efficacy for pemetrexed. And pemetrexed is one of those chemotherapies that we use generally very commonly in combination with other anti-cancer therapies in early or later stage non-small cell lung cancer. So the idea is that pemetrexed is likely going to have less benefit in these tumors. And historically, it has also been seen when you give platinum etoposide to these individuals, they may not respond as well as small cell does. Why? That's not completely clear, but historical data does suggest that LC-NEC tumors do not respond as well to platinum etoposide as extensive stage small cell lung cancer. And this is just some data to put things in perspective. When you compare cisplatin etoposide in small cell versus large cell, so first of all, there's not a lot of data out there, very few prospective trials. But this trial, 2013 trial with 14 patients, was one prospective trial in advanced stage large cell neuroendocrine tumors with cisplatin etoposide. And as you see here, I've given the PFS and OS. The PFS is 5.2 months, the OS is 7.7 months. And the same regimen in the JCO 2006 paper, which is a small cell lung cancer trial, larger trial, and this is, just to put things in perspective, this is cross-trial comparison, which is not necessarily going to be accurate, but gives us an idea. So you have an OS overall survival of 7.7 months in the large cell cohort in one trial, and you have an OS of 10.2 months with the same regimen in small cell lung cancer in another cohort. So that tells you that these tumors may not necessarily do well with checkpoint therapy. Again, on the right, I've tried to highlight or condense data from two different trials. This is the DART trial, which is the dual checkpoint therapy trial that was run by the National Cancer Institute. It was a very successful trial that incorporated a lot of rare tumors, including high-grade neuroendocrine tumors that I'm pretty sure many in the audience will be well aware of. And the interesting thing is in the DART trial, 3 large cell neuroendocrine carcinomas of the lung were included. And out of those 3, 2 patients actually had responses. Now, again, very small cohort, but this gives an idea that perhaps doublet checkpoint therapy works in these tumors. And if you compare that to small cell, on the other hand, this trial from 2020, the Checkmate 032 trial of 147 individuals with nivolumab, ipilimumab, in a slightly different combination approach and a maintenance approach, did not yield as exciting results as one would have expected. So there's something there biologically that maybe large cell neuroendocrine tumors benefit more with checkpoint therapy than perhaps small cell lung cancer. There is data looking at molecular biomarkers in large cell neuroendocrine tumors, and there's some data suggesting that when you have a non-small cell lung cancer-based approach, meaning that you have treatments that are that contain gemcitabine or paclitaxel, which we give for individuals with non-small cell lung cancer, there's some indications that if you have this gene RB1 that is wild type or non-mutated, those individuals tend to benefit better with non-small cell-like regimens. As you see here, the survival curve seems a little better for the non-small cell lung regimen for individuals that have an RB1 wild type. And versus when you have RB1 mutated, those individuals don't do as well with the non-small cell lung cancer regimen. And this group also looked at something that I found was very interesting. They looked at the expression score for RB1. So mutation of a gene can lead to lack of expression of that gene when you test for immunohistochemical markers or on an RNA expression level. So basically, not all RB1 mutant tumors have RB1 loss on IHC, but they looked at mutational aspect and they looked at the IHC aspect. And when they did the IHC aspect in tumors that had IHC score of greater than 50, meaning that the RB1 staining was intact on the tumor. So RB1 wild type or IHC staining showing the presence of the RB1 protein, because if the protein is or the gene is mutated, the protein will not show on the IHC. But here they looked at the H score, which is the more your H score, the highly likely presence of the RB1 expression on the IHC. And that they saw that that was a better predictor of response to this gemcitabine paclitaxel or taxane-based approach that is used for non-small cell lung cancer. But currently, this is not ready for prime time, so it's not like we use this day in and day out. But could this potentially lead to novel approaches where we do a biomarker-driven stratification of these tumors for treatment purposes? I think it brings into a lot of newer concepts and questions into the picture. Now, the hot topic these days is immunotherapy. It is being used in non-small cell lung cancer. It is being used in small cell lung cancer based on prospective data. There is no trials that have currently been published to date showing benefit of immune checkpoint in large cell. There is retrospective data, and we are working on developing some trials in that space, but there is retrospective data, as you see here, from single or multi-center sites looking at immune checkpoints in the second line, especially in individuals who have progressed after chemo. And the general idea is median progression-free survival of around 4.5 months and median overall survival of around a year, which is kind of similar to small cell when you think about it, and a response rate in the range of 30 to 35%, as is shown here using the single center experience. There's also some multi-center data, as is shown here, where in this specific publication that was from Israel, they looked at single agent checkpoint or doublet checkpoint inhibitors, and most of them were second line again, not first line. The median overall survival was again 11 months. And on the right, you see two survival curves, but I want to have you focus your attention on the overall survival curve that is to the extreme right, which is basically comparing individuals that got immune checkpoint inhibitors to no immune checkpoint inhibitors. And it's 37 versus 37 individuals. This is, again, retrospective data, but they did do a propensity matched cohort. So they matched for a couple of variables in their entire data set so that they could account for some of the differences between the clinical characteristics of the two patient populations. And they did see some level of benefit, median survival benefit around 4 months, as you see here, 12.5 months in the immune checkpoint cohort, and in the no immune checkpoint cohort, it was around 8.4 months, around a 4.5 month benefit with immunotherapy in this population. There's also some data from National Cancer Database where a group compared 37 patients to 624 patients, and these 37 received immunotherapy. Again, a propensity matched analysis on the right, as you see, where the individuals who did get immunotherapy fared somewhat better than individuals who did not get immune checkpoint therapy, suggesting that there is some level of benefit there. There are ongoing immunotherapy trials in this space. There's 2 trials, both of them are in Europe. These are single-arm trials. One is durvalumab in combination with carboplatin etoposide, followed by durvalumab maintenance. Then there's also a single-arm trial for atezolizumab, platinum etoposide, and then atezolizumab maintenance. And these are trials, as I've highlighted here, the LC-NEC Alpine trial and the DUPO trial. But unfortunately, there's no other trials, no other randomized studies in this space, and both of these trials are limited patient population trials. Now, again, going back to the genomics of large cell, I had a patient who had a tumor mutational burden. I've shown their profile here of 149 mutations per megabase on the tissue on the right. On the left is a liquid biopsy snapshot. Liquid biopsy showed tumor mutational burden of 23, which is pretty high. And they didn't have any other actionable alteration, so I treated them with atezolizumab, carboplatin etoposide, based on a small cell-like approach because their disease was pretty aggressive. You see here their mediastinal mass, and on the left below, they also had a subcutaneous tissue lesion, and the right is after 4 cycles. So they had a response with atezo-carboetoposide after 4 cycles, but unfortunately, after the 4 cycles and the first set of response, 2 months later, this individual's tumor progressed. Their tumor worsened, and then I had to put them on a clinical trial, and they didn't do as well. And unfortunately, the individual passed away a few months back. So again, bringing into question that does tumor mutational burden here actually suggest anything at all? Because in lung cancer, non-small cell lung cancer, adenocarcinomas, if you have a tumor mutational burden of 149 or in the liquid biopsy mutational burden of more than 20, there's a high likely chance that your tumor will respond, and then your tumor will continue to respond with immunotherapy. But that's not the case here. So that again brings into question that what is the right biomarker for these individuals' tumors that would help us understand what to treat them with, how to treat them. So we have a large multi-center retrospective study that we are currently doing and have submitted an abstract to the annual American Society of Clinical Oncology. This is being led by a fellow from Yale, Dr. Amin Nasser, and co-led by myself and Dr. Ann Chang from Yale Cancer Center, where we're looking at real-world patterns of treatment for large cell neuroendocrine carcinomas and also doing some biomarker analysis. And some of the overarching aims are to understand what treatments potentially fare better, how are the outcomes, what are the common regimens that are used, because there's just not a lot of data in this tumor type. And we had close to 160 patient data, clinical data that we collected in these individuals across, I think, 15 or 20 centers across the US, some centers from Europe also. So it's an international retrospective registry study that we are currently doing. And this is just some highlights from the data. But I think more or less the important thing here is that when you look at treatment regimens in this cohort, a decent proportion of individuals in the first line advanced/metastatic setting had chemotherapy alone. A few patients, 11 individuals, had immunotherapy alone, and then a decent proportion had chemoimmunotherapy. And the interesting thing was there was somewhat of an equal, maybe higher distribution for small cell-like regimen, which is the atezo-carboetoposide. Around 43% of individuals that got first-line chemoimmunotherapy were treated using the small cell-like regimen, and around 31% had the non-small cell-like regimen. So again, this tells you that there's no consensus on treatment of these tumors. Nobody knows how to approach them. Do we treat them like small cell? Do we treat them like non-small cell? Should we treat them based on their genomics? A lot of questions come up, and I'll highlight some of that in the next few slides. From a toxicity standpoint, in our data set, we didn't see any significant difference when you compare chemotherapy to immunotherapy or immunotherapy alone as far as grade 3 or higher toxicities are concerned. As expected, there were a few grade 3 or higher toxicities with chemoimmunotherapy compared to chemotherapy alone, but it was not significantly different, suggesting that there's not a lot of safety issues there. But the interesting thing was, even though this is a retrospective study and the data that I'm showing is not, this is an ongoing data set that we're collecting, and the data I'm showing is definitely not the final data cutoff, but you don't see a difference for chemotherapy versus immunotherapy versus chemoimmunotherapy in this cohort. Unfortunately, the response rate in our cohort was 35% for chemo, around 25% for immunotherapy, around 35% for chemoimmuno, suggesting that they kind of fall in the same ballpark range. And when you look at the survival curves, the progression-free survival on the left and the overall survival on the right, you see that there's hardly any difference for these individuals. And this is actually the largest data set to date for large cell neuroendocrine carcinomas of the lung from a retrospective registry standpoint, suggesting that we likely do not or have not figured out the right approach to treat this unique tumor. If you go from a conceptual context again, STK11 and KEAP1 mutations are common in non-small cell lung cancer. And it is a known fact that when you have STK11 and KEAP1, those individual tumors don't do as well with immune checkpoint therapy. I've shown you two different data sets. Slight credit to one of my friends, Dr. Biagio Ricciuti from Dana-Farber, where basically one of their papers, they showed that when you have KRAS mutant tumors with KEAP1 mutations or KRAS mutant tumors with STK11 mutations, as is shown in the survival curves, the blue line being the wild type. So the wild types do better. The tumors that are not mutated do better with immunotherapy than the tumors that are mutated. And I'll put this into perspective with large cell tumors, since these are two mutations we do see in large cell neuroendocrine carcinomas. And then when you compare the chemo ICI or chemoimmunotherapy, which is commonly used in non-small cell lung cancer, this is a network meta-analysis that they did. And again, they see that there's worse survival with chemoimmunotherapy also. So the Kaplan-Meier curves above are with immunotherapy alone, and the data below is with chemoimmunotherapy. There's worse progression-free survival when KEAP1 and STK11 mutations are present. So then the question is that if you have large cell neuroendocrine tumors that have STK11 and KEAP1, should you put the non-small cell lung cancer data into perspective and think of novel approaches? If you look at this slide, the message here is that STK11 mutant tumors, when you combine data from different studies, seem to do better with doublet checkpoint therapies, and same thing with KEAP1 mutant tumors. So could that also mean that STK11 mutant large cell neuroendocrine tumors or KEAP1 mutant large cell neuroendocrine tumors could do better with doublet checkpoint therapy? So I think that's, of course, it's NCCN recommendations do mention that you can use a doublet checkpoint therapy with chemotherapy in large cell neuroendocrine tumors, but I don't think we necessarily know if that approach is potentially better or not. And some other, I am somebody who's very interested in biomarkers and biology of cancer. If you look at small cell lung cancer, it exists at a spectrum, and there's different subtyping of small cell based on RNA expression. There's 4 general subtypes that have been currently described. They're ASCL1, NeuroD1, YAP1, PAU2F3. And the idea is, as you see in the middle figure below, the idea is that as you move from an ASCL1 phenotype to a YAP1 phenotype in small cell lung cancer, there is upregulation of Notch signaling. And Notch signaling is involved in cell proliferation and other aspects of immune regulation. So Notch signaling, basically YAP1 tumors or small cell that are YAP1 classified have high Notch signaling. And the idea here is that Notch signaling tumors likely respond better to immune checkpoint therapy. The figure on the right is basically data from this Nature Communications paper of 2021, showing that when you compare individual tumors that had clinical benefit or responses to immunotherapy and these are small cell lung cancer tumors, to individual tumors that did not have responses. The individual tumors that had higher Notch signaling fared better or had better outcomes to immune checkpoint therapy. Now, if you extrapolate that data, which means that the YAP1 phenotype, and it's a known fact that YAP1 is one of those phenotypes, or small cell SCLC I, or inflamed phenotype, are those phenotypes that respond to checkpoint therapy, and they have high Notch signaling. If you extrapolate that data to large cell neuroendocrine carcinomas, as I mentioned on the left, I've shown you a figure suggesting that type 2 large cell neuroendocrine carcinomas have high Notch signaling. So could they be a subset of tumors that actually respond very well to checkpoint therapy? And I think that's a question that's not been answered yet, but we are looking at it, and hopefully we'll plan to work in that space to develop appropriate and rational combination trial approaches. So I think the idea of this talk is to open the debate and help come up with questions that need to be answered in this area of unmet need. It was not necessarily meant to tell you that we have solved it all and this is the tumor type where we're making a lot of inroads in, but rather vice versa, where we need to highlight some of the issues around lack of trials, lack of data, lack of biomarkers in pulmonary large cell neuroendocrine carcinomas. And some of the emerging questions are, do we know that whether this RB1 mutation is something that we need to account for when we offer chemotherapy or chemoimmunotherapy to these individuals? Do we know what are the best combination checkpoint inhibitors in this tumor type? Should we treat these tumors based on their genomic complexity, or should we treat them based on their RNA signature complexity? Do we know if there's a role for molecularly different targeted therapy? For example, there are inhibitors for MTAP, which seems to be altered in these tumors. There are inhibitors for CDK, or there are CDK inhibitors that are currently approved or are in development that can be potentially used here. And also, a big question is, should these individuals get prophylactic cranial radiation, which we kind of have tried to shy away from slowly and steadily in small cell lung cancer. But I do try to get every 3 to 4 month brain MRIs in pulmonary large cell neuroendocrine carcinomas. As I mentioned earlier, they have a high tendency to go to and metastasize to the brain also. So more perspective and biomarker data are basically needed in this area of unmet need is what I wanted to highlight. And we are working on multiple fronts, trying to develop trials and doing some translational analysis to help hopefully expand this field in the near future. I think that was it. Thank you so much. And these are some pictures that I took from a recent vacation to when I went to one of the national parks in the US, where we saw some bisons, saw some interesting natural lakes, and a lot of other hiking and fun stuff. So thank you so much for your time. I'd like to thank my collaborators, all the patients, of course, and their families, because of without whom we would not necessarily be able to do any of our research or help develop the field, move the needle. Dr. Amin Nasser for all the collaborations that we currently have, Dr. Kareem, who was the one who recommended me for this talk and was a good friend of mine, Dr. Sen, who is a close translational collaborator, Dr. O, who's one of my translational collaborators here at the Stephenson Cancer Center, and many others who go beyond this slide. So thank you again for your time.
Thank you so much, Dr. Naqash, for an excellent talk. I really enjoyed that. We've got a little bit of time for questions. I do have some, but before I jump into that, I'm going to open it up to everyone else if you have any questions for our speaker.
Rachel, let me ask your question. So we are working on Notch and ACO1, and I was wondering, because you mentioned Notch signaling, we know there are 4 isoforms. Some people do not believe that Notch4 really exists, but in one slide you showed Notch2. Do you know which specifically isoforms play a role in those cancers?
So are you asking which isoform of Notch plays a
Yes.
role?
Mhm.
I do not know the answer to that because we don't have any data in that space. In fact, again, you mentioned that you're working on Notch, and I agree there's controversy around the 4 subtypes, and small cell tends to be a very controversial topic, nevertheless. But I don't think there's even data, and you can correct me if I'm wrong, which Notch subtype has an immune inflammatory signature in small cell lung cancer. As far as I know,
No.
all that has been studied or published to date is that Notch upregulation is common in the small cell subsets that seem to respond well to checkpoint therapy.
Mhm.
But in the context of large cell, I do not know the answer to that because it's not been studied. So might be something that we may study once we have all our translational data.
Yeah, I see. I just saw on one slide Notch2, and actually we think that Notch2 may have oncogenic role. However, the Notch2 is the least studied isoform from Notch signaling.
I see.
Great talk. Thank you. Rachel?
Any other questions from our audience?
I know I came a little bit late, but I would be curious, is there any role for evaluating DMMR status or microsatellite status, and honestly, to a much lesser extent, TMB within these type of cancers?
So your question is there a role for identifying DNA damage status or other biomarker status? Is that what your question is?
Specifically DMMR, MLH1, PMS2.
Right. Well, so as part of the NGS, at least what we do, and it differs from country to country or area to area, but these are broad panels, and these broad panels actually do MSI testing, DMMR testing in all tumors. So if we send a large cell tumor, it gets tested for the same set of genes, and we use a whole exome, whole transcriptome panel, which is pretty broad. It's not our internal panel. We send it out to a company for testing, and there's different platforms that get used currently in the US. So to answer your question, I think as part of standard of care testing, every tumor should have DMMR testing done, whether it's in-house or because you don't want to miss those individuals. We recently had a cancer cell paper a couple of weeks back, which was again DMMR testing in endometrial cancers and also uterine cancers, and I believe colorectal cancer, I believe, was part of that cohort. And what we did see that when you do DMMR testing using IHC, it can miss a certain proportion of patients compared to when you do it via NGS. And we projected that number to be around 1,100 to 1,200 individuals per year, which is a huge number if you think about the level of benefit with checkpoint therapy in DMMR patients. So if there's one biomarker that has actually proven to be beneficial from a clinical standpoint, it is DMMR testing, mismatch repair testing. PDL1 maybe to some extent, TMB to some extent, but that MMR is one true biomarker that actually leads to immunotherapy initiation, and then a large proportion of patients, maybe not all, but significant proportion of individuals benefit from that therapy. So you definitely don't want to miss out on that, and that's the standard of care test that should be done on all tumors.
Okay, I guess in relation to large cell neuroendocrine carcinoma, I did a quick Google search. I didn't see much data in terms of evaluating DMMR within these tumors. I wonder.
Right. So the data that I showed actually, I think this was CARES data from several years back. I showed you an ASCO abstract where 70% of tumors were non-small cell-like and 20% or 25% were small cell-like. And we are currently working on another collaboration. There's hardly any DMMR tumors in that subset. In fact, the lung cancer, it's like less than 1% of lung cancers are DMMR, MSI high or mismatch repair deficient. So it's not a lot, but that one individual, do you want to miss it? No. So likely the data that you're seeing on your search is because in a cohort of 50 patients, you're unlikely to find one large cell neuroendocrine tumor that is MMR deficient. but we have a much bigger collaboration with a certain company where 500, 600, 700 tumors are being analyzed. And there's a very few individuals that are MSI high, but again, it's not like on the magnitude of 5-10%.
Okay, thank you for the explanation.
Sure.
Wonderful. Do we have any other questions? And then people are also welcome to put questions in the chat, and I can read them. So I did have a question. Dr. Naqash, Renata and I are PhD scientists studying neuroendocrine cancer, so that's where our perspective comes from. We're not on the clinical side, but I did have a question. If you had any thoughts or opinions about maybe the cell of origin from large cell neuroendocrine carcinoma. That's something that I've kind of been interested in. Does this come from a cell type? Does it transform from, atypical, typical carcinoid? What are your thoughts on
My
origin?
thoughts are, and these are my thoughts. It's not based on data that I can point out to or support. If you have a transcriptional signature that is mixed, that likely means there's some level of transformation. So if you go to small cell again, the story is 10 years back, small cell was one tumor type, right? Now it is a subset of different tumors. Like 3 years back, people said, oh, this is 4 subsets in small cell. And now people are saying they may exist over a continuum in the same individual. In fact, like if you biopsy, you will see all 4 subtypes potentially in different areas. And we have some existing collaborations in that space. We're looking at RNA-seq data and showing that they don't necessarily, these subtypes are not mutually exclusive, which also means that if you extrapolate the same data to large cell, there is some overlap or a decent amount of overlap, which also suggests that, of course, these are neuroendocrine tumors. They have to be positive for neuroendocrine markers to be classified as large cell neuroendocrine carcinomas. But, based on, let's say, Notch signaling. So if Notch signaling, Notch upregulation leads to less neuroendocrine phenotype, right? If you extrapolate the data from small cell, could you have a phenotype of large cell that is Notch high and maybe does not stain for CD56 or synaptophysin, but are still neuroendocrine tumors potentially? So I think slowly and steadily, we are going to move away from just IHC-based or morphological diagnosis. I think a lot of it will be based on molecular signatures, and a lot of it will be based on RNA signatures. Currently, some platforms have this approach of, you could call it cell of origin or tumor of origin. If you have a carcinoma of unknown primary, based on the RNA signature, they will say that likely that this is coming from the bladder, not from the lung. So even though the mass is in the lung, but you treat it as bladder cancer because that's how the tumor is biologically behaving. So to put this into context of what your question is, I think it does originate from neuroendocrine cells, but do those neuroendocrine cells transform, hypermutate, alter over time in some ways, likely leading to the presentation that large cell has? That's what I feel. But I think to get to the bottom of this, you probably need something like a rapid autopsy program that some folks in the country have done for small cell, where if you have a rapid autopsy program, you get all the tumor tissue from an individual and then analyze all the areas, different areas, do spatial transcriptomics, or RNA-seq, obviously, maybe even single-cell RNA-seq, that could probably tell you the trajectory of the cells to better understand what is the cell of origin. So I think it's a mixture of things right now because there's just no data. And I don't think just RNA sequencing is going to tell you that. Probably needs something more deeper on the level of high-end spatial transcriptomics and single-cell omics to understand the cell of origin. So hopefully that helps answer your question to some extent.
Absolutely. And I agree. It's so incredibly complex, and these neuroendocrine cancers of the lungs, there's so many different types, and within each tumor, it's so heterogeneous. I always think, I'm like, did this come from the same cell, or we've got a group of cells, or it's an interesting thought for me.
Which is why if you go back to this,
complex.
right, and which is why if you go back to the small cell story, that's a great example where you have phase 3 trials that are necessarily, FDA approved now in Europe and the US. We use checkpoint inhibitors, but the median survival differences are on the lines of 1 to 2 months on the trials. So every time you treat somebody in the real world setting, you don't necessarily see the same level of benefit that you see in a clinical trial, because there's obviously, the kind of patient population, et cetera, et cetera. And in the small cell world also, the level of heterogeneity is so much that there is a subset that responds well, and there's a subset that does not respond well. So my theory is that it's probably very similar here in large cell. There's a subset that responds to checkpoint-based therapy, and there's likely a subset that would respond to precision medicine-based approaches because of the alterations that they have. So I think having, a sort of a umbrella and a basket trial approach where you try to stratify these individuals based on some of these things, I think is going to be critical.
Yeah, I agree. Definitely, it's trying to figure out that pattern. And it's probably, like you mentioned, more than just some RNA sequencing. There's different layers that we need to look at and have a more comprehensive biomarker approach to identify and stratify these patients because of the complexity and heterogeneity in, this umbrella tumor type. So thank you. So that does put us right at time. If anyone else has a quick question, feel free to ask or reach out to our speaker. But I just want to thank you again, Dr. Naqash, for coming and speaking to us today. Selena, would you like to say some final words?
Well, thank you for your talk. Thank you for giving us your time, and thank you for all the great questions. And just to remind everyone that our next meeting will be on Thursday, the 28th of March, same time. And Dr. Naqash, are you happy for me to add you to our list so that we can send you invites for our meetings?
Sure.
We'd love to
Sounds
see
good.
you again.
Thank
Okay,
you so much. Thanks.
Thank you
Thanks,
very
everyone.
much, everyone, for coming, and we will see you all next month.
Take care. Bye-bye.
Thank
Thanks.
Thank you. Thanks.
Bye.
Bye-bye.
Thank you all. Bye.